Let's have a discussion on upper limb trauma. You know, majority of the questions after peripheral nerve injury are asked from this topic, that is upper limb trauma. Now, in this particular scenario, we are going to have a discussion on bony injuries to the upper limb, starting right from the clavicle up to the level of the phalanges. The initial topic, which is considered to be the most commonly asked topic out of this upper limb trauma, is the dislocation pattern. Now, I am giving you some of the prototype questions before actually talking about the topic. Now, one of this question is that a 27-year-old male who has sustained injury to his right shoulder, all right, now falling from an electric pole due to electric shock. Now, this is the etiology, this is the mode of injury which is kept in your question due to the electric shock. Now, following which his arm was fixed in adduction and internal rotation. Now, by the time the patient comes to you, he is having some abnormal attitude of that upper limb, and that abnormality is that his arm on the affected side is fixed in adduction and in internal rotation, slight internal rotation. So, what is the most probable diagnosis for this particular case? Alright, so this is one question. Now, in this question, what are the two components which are provided to you? One is that there is a history, that means etiology is provided, and second is the examination finding. That means on presentation, what is the attitude the patient is suffering from. Now, this is one prototype question. The another one is, similarly, we have got another question like, which of the following is incorrect for anterior dislocation of the shoulder? Now, as you will come to know about, that dislocation of the shoulder has got three different patterns based upon the position of the head of the humerus which got dislocated in relation to the glenoid. Alright, so it could be anterior, posterior and inferior. Now, they are asking that what is the abnormal position in which the limb would be kept once the patient has sustained the anterior dislocation of the shoulder, and you have to find out that which one is the incorrect pattern. Alright, so these are the questions. With these questions in your background or in your head, let's have a discussion on the first topic, that is dislocation of the shoulder. Now, as I told you already, that shoulder dislocation could be categorized into three different categories. The first one is the anterior dislocation of the shoulder. Anterior dislocation means when the head of the humerus is moved anterior to the glenoid. The second one is posterior dislocation of the shoulder, and the third one is inferior dislocation. Out of these three patterns, the most common is the anterior dislocation. So, it is considered to be the most common pattern. Alright, while the least common is the inferior dislocation of the shoulder. It is considered to be the least common one. Let us start with the anterior dislocation of the shoulder first. Now, as the heading indicates, the anterior dislocation of the shoulder means when the glenoid comes, that means head of the humerus comes in front of the glenoid. So, point number one, what is the mode of injury or the mechanism of injury for this kind of a shoulder dislocation? Now, the mechanism is when a patient fall on outstretched hand. You know, although any mode of injury which has resulted in the external and abduction of the arm can result in anterior dislocation, but you know, fall on outstretched hand or fall on outstretched arm is considered to be the mode of injury theoretically for anterior dislocation of the shoulder. So, it is fall on outstretched arm. Now, point number two, that if the patient is falling on outstretched arm, what is the position in which the arm is held? For example, you know, normally or practically, if a patient is made to fall, then he will fall on outstretched arm only. It is almost impossible until and unless the patient is not conscious that he will not fall with the outstretched arm. This is the only position in which he will fall, because he will try to protect his centrally lying vital organs in order to prevent it from injury. Alright, so fall on outstretched arm means there is a fall on abducted and externally rotated arm. That means fall on abducted and externally rotated arm. Alright, so that is the mechanism. Now, initially in your questions, how they used to ask the questions were that there is a fall on outstretched arm, but now you should be able to understand that what is the meaning of this outstretched arm. It is in abduction and externally rotated position. But now, point number two, that what is the most common nerve injury? Now, it is not very difficult to understand. We have already discussed this before also. Like the most common nerve injury associated with this anterior dislocation or posterior dislocation of the shoulder is the axillary nerve. The nerve which is lying in close proximity to the proximal part of the humerus might get, because of this stretching, might result in a various patterns of injury could be observed based on this dislocations of the shoulder in that particular axillary nerve. Now, point number 3, that what is the attitude? As we already came to know, that attitude means abnormal position in which the limb would be kept. So, it is the abnormal position of the limb. Abnormal position in which the limb would be kept. Now, just try to understand. A patient who has sustained the anterior dislocation of the shoulder. So, imagine this is the glenoid, this is head of the humerus, and this is anterior dislocation of the shoulder. When it is dislocated anteriorly, the head of the humerus would be lying on the medial aspect, as a result of which the lateral musculature will be contracting and it will raise the arm into abduction. So, one of the attitude is abduction. Then the second one, when it is moved anteriorly, it is the posterior rotator which will be more stretched, and because of this more stretching of this external rotators, there will be more rebound contraction, as a result of which this anteriorly dislocated head of the humerus would be externally rotated. So, there will be abduction and external rotation. Now, point number 3, when the head of the humerus has glided or moved anterior to the glenoid, so it will result in a condition which is acutely painful for the patient. And how the patient will react to this pain? By holding it. In order to hold the elbow of the affected limb by the opposite normal limb, he has to flex the arm. As a result of which, one of the attitude which is found to be there in conjunction to this abduction and external rotation is the flexion. Alright. So, the patient would be presenting with flexion, abduction and external rotation. Now, imagine if the patient comes to you in the emergency, and just by looking at the patient, you can diagnose that he probably is suffering from this anterior dislocation of the shoulder joint. Alright. Now, apart from this, there are several tests which are considered to be core clinical test, on the basis of which you will be able to diagnose whether the patient is suffering from anterior dislocation of the shoulder or not. Alright. So, as far as these clinical tests are concerned, the first one is Dugas test. Now, what is Dugas test? It is inability to touch the opposite shoulder. Alright, inability to touch the opposite shoulder. Now, imagine if the patient is not able to, if the patient is having abducted and externally rotated arm, and he is not able to touch the opposite shoulder. Means imagine if you ask a patient to touch the opposite shoulder, he won't be able to reach the opposite shoulder with his hand of the limb which is anteriorly dislocated. Alright. So, that is one Dugas test. Second one is Hamilton ruler test. Now, in this Hamilton ruler test, what is happening, that imagine when you ask a patient, when you put a scale, a metallic scale, by the ends of the acromion and the lateral epicondyle, then the two ends of this solid metallic scale would be able to touch them simultaneously in case of anteriorly dislocated shoulder. But in case a person who is having a normal shoulder without any dislocation, you won't be able to touch the two processes simultaneously. Alright. So, in case of Hamilton ruler test, what you get in anterior dislocation of the shoulder is that there is a simultaneous touch to both acromion and lateral epicondyle. Alright. In case of normal individual without any anterior dislocation, it is impossible to touch both the ends of the rigid ruler simultaneously by these two bony prominences. Alright. So, that is Hamilton ruler test. And the third one is Callaway test. Now, as far as this Callaway test is concerned, now what happens in case of Callaway test, that there is increased anteroposterior diameter of the axilla. Imagine this is the axillary border. Here we are having the anterior point, here we are having the posterior point. Now, when the head of the humerus moves anteriorly, so you have to calculate this anterior end of the humerus also in order to measure the, yes. So, this Callaway test is increased anteroposterior diameter of the axilla. increase anteroposterior diameter to the axilla. So these are the three clinical tests on the basis of which you will diagnose whether the patient is suffering from anterior dislocation of the shoulder or not. All right. Now, what we have till now discussed, we have discussed the mechanism of injury, the most common nerve which is found to be injured. The third one is the most important point, that is dislocation attitude, that what is the attitude with which the patient will be coming to you. And the fourth point is what are the names of the test. Now, the fifth point is that is there any investigation on the basis of which you will be able to diagnose this anterior dislocation of the shoulder or not. Now, as far as the investigations are concerned, the diagnosis is entirely clinical. The diagnosis is clinical. But as far as the x-rays are concerned, because you have to get the x-ray for the documentation purposes, now there are two views which are required. One is AP and the other one is axillary view. Alright, AP and the axillary view. Now on this AP view, what you are going to get only is that the head of the humerus is out of the glenoid. It is not there inside the glenoid cavity. Alright, there is a dislocation. Now whether this dislocation is anterior or posterior to the glenoid, you won't be able to tell on the basis of AP view only. Alright, so both AP and the axillary views are required in order to have this diagnosis of anterior dislocation of the shoulder. So these x-rays are enough for making the diagnosis, although the diagnosis is made pure clinically. Then apart from this, the next point about the anterior dislocation of the shoulder is that what is the treatment. Now as far as this treatment is concerned, the treatment is closed reduction by, you can go with this closed reduction method. Now closed reduction by Kocher's method. One of the method is Kocher's method, then the second one is the Stimson's method, and the third one is Hippocrates method. Alright, so Kocher's, Stimson's and Hippocrates. So these are the three methods on the basis of which you can perform this closed reduction in the emergency itself. Now the Kocher's method is the most commonly used method. Alright, as far as the Kocher's method is concerned, if you look at this image, what is happening, that you are asking a patient to lie supine on couch. Once the patient is lying supine on couch, then what you perform is traction. First you go ahead with the traction, then you go for external rotation, then you go for adduction, and then finally internal rotation. Alright, so what are the steps which you are following is that while applying traction, you are performing this external rotation, then adduction and internal rotation. With this Kocher's method, the head of the humerus which is acutely dislocated would be reduced back into position, and it is considered to be the most commonly used method, the Kocher's method. Now there are other methods also, like Stimson's method. I told you the second one is Stimson's method. Now in this Stimson's method, what is happening, that this is the method where you are waiting for spontaneous reduction. Means you are not applying any traction, you are just using the gravitational force for this traction to get applied. So you make the patient lie prone on couch with the affected limb made to dangle by the side of the couch. Some of the weight is tied onto that affected limb, and then you wait for a spontaneous reduction to happen. So Stimson's method is a method which is using a spontaneous reduction using gravity. Alright, so gravitational assist is required for this shoulder to get reduced back into a position. And the third one that you have written is the Hippocrates method. Now in Hippocrates method, what is happening, that your foot, that means the foot of the surgeon, is there in the axle of the patient, and the surgeon applies the tractional force. With the use of this foot, he tries to maneuver the head of the humerus back into its position. Alright, so this is the Hippocrates method. So obviously, just by looking at these methods, the best method to be used for the purpose of reduction is Kocher's method, and that for obvious reason, Kocher method is considered to be the method most commonly used for the purpose of reduction. Alright, so this is about the management. That means Kocher's, Stimson and Hippocrates method. But out of these three methods, which one is having the highest incidence of neurovascular injury? Kocher's method is having the highest incidence